Hi everyone, my name is Sharvani Mishra, and today I will be presenting about the role of non-coding DNA in global cancer inequities, and how ignoring this type of DNA leads to deepening the divide between high-income countries versus low and middle-income countries. So here's a little bit about me. I'm a rising 10th grader at the Overlake School in Redmond, Washington. I'm passionate about medicine, genetics, and global health equity. I've studied global health through the University of Washington, researched cancer genomics, and co-run a platform focused on international health systems and innovations. One day, I hope to become a doctor who not only treats patients, but also advances research to improve care in underserved communities around the world. Today, I'll be exploring how these overlooked mutations in non-coding DNA play a key role in cancer and how our global failure to detect them contributes to inequities between high-income and low and middle-income countries. This matters because cancer is becoming one of the largest contributors to the global health burden, which is the total impact of disease on populations, including illness, disability, and premature death. In 2020 alone, cancer was responsible for nearly 10 million deaths worldwide, making it the second leading cause of death globally. And of those deaths, 70% of them were in low and middle income countries. By 2040, new cancer cases in these regions are expected to double. We often think of cancer mutations as changes in protein coding genes like BRCA1 or TP53, but those only make up about 2% of our genome. The other 98% was once dismissed as junk DNA, but is now known as non-coding DNA that controls when and how genes are expressed. Mutations in these regions, like promoters or enhancers, can activate oncogenes, silence tumor suppressors, and drive cancer just as powerfully as mutations in coding regions. Let's take a closer look. Promoters and enhancers are regulatory DNA sequences that act like switches, controlling when, where, and how much a gene is expressed. When mutated, they can activate cancer genes at the wrong time, and sometimes permanently. One of the most well-known examples is the TRT promoter mutation. TRT encodes telomerase, an enzyme that helps cells divide. Normally, it's turned off, but in many cancers, including brain, liver, and thyroid cancers, mutations in its promoter turn it back on, allowing cells to divide indefinitely. Yet most hospital genetic panels still focused on only coding regions, overlooking non-coding mutations in promoters, enhancers, or untranslated regions. For example, the widely used Foundation 1 CDX panel analyzes over 300 genes, but only their coding portions, ignoring regulatory elements unless already well known, like the TRT promoter. And this isn't rare. A 2020 review in Nature's Reviews Genetics found that fewer than 10% of commercial cancer panels screen for non-coding variants. The result? Tumors can be misclassified, leading to delayed or ineffective treatment. Even in high-income countries, these blind spots persist, and in lower resource settings where full genome sequencing is rare, the risk of missing key mutations is even higher. Non-coding DNA also produces non-coding RNAs, like microRNAs, LNC RNAs, and circular RNAs, that don't code for proteins but regulate how they function. These molecules influence gene silencing, immune evasion, and more. Studies show that dysregulated non-coding RNAs contribute to chemotherapy resistance, metastasis, and tumor immune escape. Yet in many low-resource settings, patients are still diagnosed using outdated tools, limited to basic pathology or small gene panels that miss these mutations entirely. While high-income countries adopt whole genome testing, the WHO reports that over half of low and middle-income countries still lack access to even basic molecular diagnostics. Let me give you two real-world examples. At St. Jude's, researchers discovered that non-coding mutations in pediatric leukemia, especially in regulatory regions like enhancers, can change how genes involved in drug metabolism or resistance are expressed. This means a child might receive the correct drug, but if a mutation in a non-coding region is turning off a key sensitivity gene or activating a resistance gene, the treatment could fail. These mutations don't affect the structure of the genes, so they wouldn't be caught by standard sequencing panels, yet they dramatically alter how a child responds to chemotherapy. Another example is the CA125 blood test for ovarian cancer. It works fairly well in white women, but studies show it's much less sensitive in Black and Native American women. Why? Because the test was calibrated on a non-diverse dataset and likely doesn't account for genomic variations, including non-coding ones, that influence CA125 levels. So it's not just about DNA, it's about who we test, how we test them, and which populations we include when building these tools. When we ignore non-coding mutations, we're not just ignoring DNA, we're ignoring people. Genomic databases are overwhelmingly made up of data from people of European ancestry. In one study of 60,000 patients, those of African ancestry were significantly less likely to qualify for precision oncology trials. That's because they didn't have the specific mutations the trials were designed to target, or more accurately, because those mutations hadn't been studied or discovered in African genomes. This is the heart of the problem. Cancer treatment is becoming more personalized, but only for those who are represented in the data. If we don't expand our view of the genome and who it applies to, we will deepen the global divide in cancer outcomes. Fortunately, there are solutions. Portable whole genome sequencing tools like Oxford Nanopore are making it possible to bring advanced diagnostics to remote clinics, even without electricity. Second, AI is helping scientists predict the impact of non-coding mutations based on DNA structure and binding patterns. A recent study from Australia used AI to find hundreds of previously unknown non-coding mutations that contribute to cancer. Third, initiatives like H3 Africa are building whole genome reference databases led by African scientists, so diverse populations are no longer excluded from the future of medicine. And finally, policy matters. Guidelines that include non-coding variants in genetic panels, especially for use in global cancer programs, can help ensure that no patient is left behind. To conclude, the majority of our genome is non-coding. We now know that this region holds powerful clues to how cancer starts, spreads, and resists treatment. But millions of people, especially in low resource settings, are being diagnosed using incomplete tools that ignore this part of the genome. To make cancer care truly equitable, we can't rely on tools and data that serve only part of the world. We must expand full genome diagnostics beyond research labs into clinics everywhere. We need genomic databases representing all populations, not just those of European ancestry. We must train a global health workforce fluent in cancer biology and genomics. Most importantly, we must commit to inclusive research that reflects the diversity of the patients we aim to help. As future global health leaders, we must ask ourselves what progress, scientific and human, is missed when parts of the genome and parts of the world remain in the dark. Now, here's just a quick look at my references. I'd like to thank the Global Health Leaders Conference at Johns Hopkins for this opportunity to share my work. I'm grateful to the University of Washington for helping spark my interest in global health, and to the researchers whose work I drew from. Finally, thank you all for your listening and for your dedication to advancing equity in healthcare around the world. Thank you. And here's my email and contact details if you want to reach out or have any questions.